This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Dr. Wendy Oliver-Pyatt. Wendy Oliver-Pyatt, MD, is a world-leading expert in mental health and eating disorder treatment and the founder of Galen Hope in South Florida and Within Health. A board-certified psychiatrist with over 25 years of experience, she is known for her innovative, humane, and dignity-enhancing approach to care. Dr. Oliver-Pyatt's treatment model addresses the underlying factors contributing to mental health conditions, empowering individuals with the skills, tools, and support to heal physically, mentally, and emotionally. She completed her specialty training at NYU Bellevue Hospital, where she served as chief resident and has held faculty positions at NYU, Albert Einstein College of Medicine, and the University of Nevada School of Medicine. Read her full bio in the show notes.
Welcome, listeners. We are so glad that you are here today, and we're excited to bring this very special interview with our dear guest, Dr. Wendy Oliver-Pyatt. She will be joining us in just a minute, but first I'd like to welcome my soulmate and my best friend, Jack Major, and our dear friend and fellow advocate, Ellen Bennett.
Welcome, listeners. Thank you for being with us again today, and I am so excited about this interview with Dr. Wendy Oliver-Pyatt. And please remember the links for Dr. Pyatt are in the show notes. So without further ado, let's go, Ellen.
Well, Ellen,
Woohoo! Thank you all for joining the conversation. We're so excited for this, for today.
And as you can tell, Ellen is always the color person.
Yeah.
God bless her. I had trouble finding a quote that said everything that I wanted to say today, so I came up with my own quote for our special guest.
This quote. Love it.
This quote is by Linda Major. Innovation and compassionate, comprehensive medical care begin by physicians following their passion, understanding their patients' needs and challenges, and ultimately developing protocols that propel the patient forward. Yeah. And without further ado, welcome Wendy Oliver-Pyatt.
Thank you both. Thank you all, Wendy. 3 of you. Thank you.
Welcome, and thank you for thank you for all you do and contribute. It is leaders like you who are really moving us forward, and we so honor all that you do.
That's so kind of you. I appreciate that.
Wendy, it was wonderful meeting you at the 2023 Meta Conference and attending your impactful presentation and having the opportunity to spend some quality time with you after our presentation. Your warmth, knowledge, and deep compassion for your patients is unsurpassed. Can you tell us when you knew you wanted to become a physician and a psychiatrist?
Sure, I would be delighted to do that. However, I want to start by saying to you, you both, Jack and Linda, that in hearing your story and in spending time with you, this is a part of what, all of us need in the field. We need those, we need reality checks. We need lived experience. We need to, set aside books and put our heart first in developing programs and in thinking about how important our work is. And every single patient that walks in our door has already suffered so much by the time they come to higher level of care. The family has already suffered so much. It's been such a project of enormous undertaking to get that person in the door. And when we in the field that are treating our patients, and we're able to hear these stories, even the tragic stories, it is a very important reminder that every experience that the patient has has the possibility to impact that person in sort of a positive or negative way. And so every communication needs to be thoughtful. We need to think of the opportunity to treat somebody as the sacred experience that it is. We need to remember how much suffering has happened by the time they come into our programs. We need to remember that even if they leave prematurely, we still have the opportunity to leave them with a positive experience that'll make it more and more likely for them to return. And we need to recognize that we have the patient maybe for 60 days or 90 days or whatever, if they do come to higher levels of care. And we need to do all we can and not drop any balls and not leave any stone unturned to make sure that they're getting what they need. Because they sacrifice so much too. Our patients sacrifice autonomy and so much by making that decision. It's a very hard decision to sacrifice your autonomy to enter into the world of a treatment community. So we owe it to patients to be kind and considerate and recognize all that they're giving up in order to be in treatment. So I wanted to start with that. And your story and meeting you, touched me deeply and stays with me. It's always in me in some way, shape, or form.
Well, you've
I
already
wanted
made
to start by just saying that.
You've already made me cry, so for the first time today. So thank you. And I know, we didn't know what to expect, and I don't want to take up a lot of time, but we didn't know what to expect when, they accepted us to speak, and didn't know how many people were going to show up in the room. It could be 2 people, 10 people, and there was 100 people there. So
it was incredibly touching. I'm glad I got to hear all about it. And I'm always willing to hear more too.
Wow, it was incredible spending that time with you. And then, you welcoming us and inviting us to join you afterwards to talk meant so much. And it speaks volumes as to who you are, for sure.
Well, and hearing your words is so beautiful for us because many times our experiences did not reflect that compassion and the shift in the focus. Joy to our heart to hear that, because what that says to me is things are really changing and shifting, that there's a new philosophy and a new approach.
Yeah. Because of leaders like you.
Yeah. And, yes. Ellen lost her daughter too, back in 2000.
I didn't know that, Ellen. I'm so sorry for your tragic loss.
Well, and thank you. That is what has brought us together. And we have that shared common ground that has really pushed all of us to tell our stories, to talk to people. And it's part of the reality. And we need to deal with all of it.
Yeah.
Of course, all we want is recovery for everyone. But this is part of it. It's like the cautionary tale. Remember. Yeah. And so thank you for honoring our path. Thank you.
There's no words for me to say that would match what I feel in my heart that I want to convey, as far as just my condolences and the energy that it gives me, in a sense, I guess, to think about the pain. And it helps me, keep putting one foot in the front of the other every day.
So can you tell us when you knew you wanted to become a physician and then a psychiatrist? Was it early on? Was it not? I don't know. And it's also wonderful that you're a mom too, that, being able to share all this on so many levels.
Yeah. Being a mom definitely is the most humbling experience in my life. How much we think we can control that we can't control, that we find that out as we manage our kids a little bit when they're younger, and then when they get older, it's like, good luck with that, But so my story goes back to a childhood where I was really committed, devoted, and had the belief that I was going to become a veterinarian most of my life. And but at some point along the way, I became a little bit more realistic with who I am and recognize that I'm not going to do very well as a veterinarian because, first of all, I'm not going to be able to put any animals to sleep. So that's just not going to work for me. I just couldn't do it. My hat is off to those who can, but it wasn't in the cards for me. So sometime in college, I kind of shifted over from being a pre-vet to being pre-med. But I really struggled in the beginning in college, by the way. And they told me, you should not think about going to medical school. You're not going to make it. So that's another discussion that I sometimes like to tell my patients because, I was discouraged at an early stage of being a pre-med and not really, growing up in an academically rigorous environment in Carson City, Nevada. But anyway, so I planned on being an OBGYN for most of my pre-med years. And then even in medical school, I continued to think I was going to do OBGYN. And then in my third year of medical school, I did a rotation in Kings County Hospital. I was a student at Downstate. I did a rotation in Kings County, which is in Brooklyn, inner city facility. And I encountered a 18-year-old man who had a first break of psychosis. And my heart went out to him. I met his family. It was just obviously devastating to, picture your child who is lucid and normally functioning to some extent, who is, bombarded with psychotic symptoms, disorganized speech, disorganized behavior. I mean, it's like losing your child and losing your grasp on reality as your child has lost grasp on reality. And within that period of time of maybe 7 to 10 days, at that time, we didn't have great psychiatric meds. We used a lot of Haldol back then, which not the best thing, but it did clear the psychosis out very quickly. And I watched this young man go from being floridly psychotic to being, reality-based and not overwhelmed by those symptoms. And I had an immediate just fascination with the mind, first of all, just like, wow, the brain, holy cow, that's phenomenal. And then also, it really struck a deep chord of compassion in me just to see somebody that overtaken by mental illness and so vulnerable. And the vulnerability there of the severe mental illness was something that it drew out the most, like the deepest part of myself of like wanting to protect, this like protection part of me that just came about me. And it was all I wanted to do to just help that person and then, relating to the family. And so it was just a fascination with that process that really got me thinking about psychiatry. And I guess one of the funny stories about me is that, many people always think that I planned this whole thing out. Oh, you had an eating disorder when you were younger. And so then that's how come you wanted to be a psychiatrist and treat eating disorders. None of that is true. I actually didn't want to treat eating disorders. Not because I would be bothered or triggered, but I was just bored with the topic itself, because just diet culture and like all this stuff that overtakes a person's brain when they have an eating disorder is like, I was just bored by it. I was like, I don't want to sit around and listen to somebody talk about their negative body image or food, or I just was like, yawn, and I was much more interested in just primary mental health, because that first patient got me going with it. And this is a story sometimes I tell the patients that has to do with intrinsic motivation versus external motivation. I think is important for eating disorder patients to think about what drives them, internal versus external drivers of behavior. For me, I was sitting in my apartment and I had the green journal, which is the American Psychiatric Association journal. I had that on my right. And then I had the OBGYN journals on my left, because I was still planning to do OBGYN, but I kept accumulating those green journals for some reason. And it just hit me that this idea hit me that if I was reading the OBGYN journals, it was because I should read them. Like I needed to have the knowledge if I was going to be an OBGYN, I needed to read those knowledge. I needed to know those articles. I needed to know the research. It was a should. And the Green Journal, it wasn't a should. It was just, I saw the articles on the cover and I was like, I want to read that article. Like, I need to read that article. I not need because of some other, it was need out of like my own hunger for the subject. And it was just like, that's internal motivation. That's intrinsic. That's me. And that was like my decision maker. I was like, I have to do the thing that really is about who I am. And it was hard. I mean, at the time I was, thinking about student loans. And I mean, I remember my father, God bless him, at the time, he developed much more psychologically as he aged, but he was very disturbed about me choosing this lowly career of psychiatry. It wasn't real medicine or whatever. He completely changed later. But so anyway, that's my story of why I ended up in psychiatry. But my first, years in the field were really around severe mental illness. And I was this medical director for the state of Nevada Division of Mental Health. And I started assertive community treatment programs for chronically mentally ill patients with the highest recidivism in the state, brought people out of the hospitals that were, had 20, 30, 40 hospitalizations or 20 years of hospitalization, brought them into the community through the PACT model. So that's the long answer, but it gives, I hope it wasn't too long.
No, it's so
God.
wonderful to hear that background, and we're so glad you followed your passion.
And again, it was just that one person that you met that you had, you understood the devastation that happened to him and the family. Yeah.
That's a good point. I think I did understand the devastation. You're right.
Yeah. So
I think that's a part of what makes a good healthcare practitioner in general is like as much as we want to move through the motions in the day and get through each patient or, work and then rest or whatever. I mean, we all want that, but before us, comes that patient and the devastation of that patient. And sometimes I just tell myself, whatever the circumstance may be, and like something comes before me and I just see, there'll be the crisis du jour or whatever. And you just have to kind of press pause on everything else and just be like, you know what, that next meeting is going to have to wait, or I'm going to have to cancel this other thing, or I'm not going to get home on time. But there's this situation. You have to always make sure you're placing room in your heart to recognize what's in front of you. Okay.
All right. Well, after we do this, we're going to get together and we're going to change the system into just what you said.
We'll try.
All right. So you founded Galen Health, which now used to have 2 locations. There's one now because you have a new residential center that just opened recently, and it's in Coral Gables, I believe, right?
Yes, we have residential, partial hospitalization, and intensive outpatient.
Right. Okay.
In Coral Gables.
And then you have this virtual treatment program called Within Health. Can you share with everybody how these treatment models differ and why you felt that they were necessary?
Oh boy, here we go. Well, I'll talk about what's like sort of in common with both of them, and then a little bit about remote care too. But what I've recognized in the field, some of the things I've recognized in the field and what's driven me to do what I do is that I believe that all of our patients need to be treated using a biopsychosocial foundation or biopsychosocial spiritual foundation. And we can't really cut corners on that. In order to understand the etiology of the conditions and the treatment plan, we have to address the patient holistically and in an integrated fashion. So it can't be like, oh, this doctor over here is treating this doctor over there is treating that. The idea that, for example, the person's going to go to a program and they're going to be in the eating disorder track for 30 days, and then they're going to go to the substance abuse track for 30 days, and then they're going to go to the as the trauma track, or these ideas that we're bifurcated human beings, like we're human beings and we have to have this biopsychosocial approach. And I think being a physician and being a psychiatrist has always guided me, because if you don't address and treat the underlying psychiatric comorbidity that inevitably does exist in patients who wind up in higher levels of care, it's, you can almost count on like one or two hands in all my decades, those that ended up in higher levels of care who didn't have co-occurring something, right? So being psychiatrically driven, I think, is a differentiator. And I think a few more things are really important. I really believe in the importance of high frequency individual therapy when people are in higher levels of care. This no fly-by-night therapy session, no 15-minute check-in. You're really engaging in a true bona fide intensive psychotherapy process where you have to sort of excavate, if you will, the underlying thoughts that are driving the behavior, that emotions that are floating around that the person is doing their best to manage, and the variables in their life that are also reinforcing the behavior. So you really have to know patients extremely well in order to accomplish recovery. You cannot skip over anything with eating disorders. The other piece of it is the family integration model that I use, which I think is really missed in the field a lot because people skip over that, or they drink the Kool-Aid the patient gives, which is like, I don't want to involve my mom, or dad. Like, no, I'm not going to sign the release of information, or which is, a common theme, which is a bit absurd. Because,
unfortunately, right?
That story. Yeah. And it's ridiculous because so often as that comes about, the person is potentially or likely to be highly dependent financially and otherwise on this person who's paying for care. And yet the patient will say they're not signing the ROI. You guys have probably all been through that.
Mm-hmm. Absolutely.
And I honestly, I'm really strict about not taking that bait from the patients. Sometimes the team gets a little frustrated with me because they're saying, but the patient doesn't want to involve the blah, 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 And so that's why there's multiple ways to approach family. You don't have to just be doing psychotherapy. If maybe the dad was reinforcing the eating disorder, maybe the mom is into dieting or whatever, those things all happen. And so we can understand why the patient might be aversive to doing psychotherapy. I get that with the family, and they're still living with the family or dependent on the family. So I take kind of a three-prong approach where you can do psychotherapy, but you can also do education and coaching. So education is important because sometimes we imagine or we think that families are going to know what we know. Families don't know what we know as eating disorder experts, right? Mm-hmm. How does the father know that he's triggering the shit out of his daughter by his own, preoccupation with health food? Or how does the family know what the risk of osteopenia or osteoporosis is? They don't even know what those words mean. Mm-hmm. So the education is important. And then sometimes it's just coaching, to be honest with you. And sometimes there are families that are really not fun to work with. And we just have to get on the phone sometimes or on a Zoom and coach them up a little bit. Sometimes we have to match the clinician with the family. Sometimes it might be the primary therapist that's going to do the coaching, but the family may be really, dismissive sometimes of the therapist. We see that a lot. And so sometimes I might just have to get on the call and kind of, if you will, lay down the law. Yeah. Mm-hmm. And sometimes I might intentionally be like, you know what, I'm not going to do it. I might choose to have a male physician call a dad, for example, or whatever. I'm just using examples. Oh, yeah. But you can really play around with it, and you don't have to just be like, oh, we're doing psychotherapy. We can find ways to work with families to help them do more. And the thing that bothers me sometimes that I see in families is when families think that by redirecting them or addressing these dynamics right, that might be driving the eating disorder behavior, if they think that you're actually blaming them, then there's going to, of course, be defensiveness. And what I try to help people see that it's not about blame. It's about the fact that we all live in this diet culture, right? We all are like mired by the impact of weight stigma in our daily lives. So helping people understand that when we are educating them or coaching them or doing therapy with them, even if it might seem like we might seem like we're blaming them, we're actually empowering them. We're helping them be more influential over their loved one.
Yeah.
Because their loved one is going to just create more barriers and walls when these dynamics just keep happening. So addressing the dynamics that could be triggering to the patient is not blaming the family, it's empowering the family. But the secret sauce, if you will, is to be able to form a connection with the family while simultaneously sometimes having to give them feedback that may not be the greatest to hear.
Yeah, that's
what I always say is love is the most important thing. And the second most important thing is the communication. And what you say isn't always what people hear. And I can only imagine as a therapist or psychiatrist or psychologist, how that must be so difficult to work on all those levels with both sides of the coin.
And it
is hard. It's really hard. It's
Yeah.
definitely an art.
Yeah.
And it is an art.
Yeah. And I always say, it's people are starting the journey with their child, whether it's at 12, 13, or like Emily, 25, or whatever age, because it can happen at any time. Is that when they don't take it seriously enough, and again, our book is the worst case scenario, okay, but that happens, and that can happen, and they need to be slapped and say, hey, listen, this is recovery is possible. Absolutely. It happens all the time, but this happens also. And, you need to address it, take it seriously, and understand it's
Well, at least people now are talking more about mental illnesses and eating disorders. And I wish I knew everything then that I've learned now. And not that anybody knows everything, but
the system let us down too. I mean, it's just,
absolutely.
What more could we,
But there's more hope now, and things are changing because of people like you, Wendy, wonderful professionals in this field.
Oh my gosh.
This
is so
The
great.
other thing just to mention that I think is super important in treatment is that there is so much attention that happens upon a patient when they're in the acute phase of illness. So it's all hands on deck. They're in the residential program or whatever. And I always say this to the team, like as we start to feel better, we as providers or we as families or our loved ones, we start to feel better as they're looking better or behaving better or whatever. A lot of times they're feeling worse. They're the most flooded that they have ever been. And so they're feeling worse and we're feeling better. And the models of care put a lot of time and energy into acute treatment and not a lot of time and energy into community reintegration. So going back to me starting those PACT programs, assertive community treatment programs, that was when it was like really locked in for me that like, hey, we have to put as much energy into the patient and the family when they're quote unquote getting better to help them build, as Marsha Linehan says, build their life worth living in their communities. And sometimes we have to be really directive and intentional, that whether it's really helping somebody enroll in a class, not just be like, go enroll in a class, but taking a care partner with them to go enroll in the class or go to do a yoga class or whatever it really means, like doing a lot of exposure therapy, going and cleaning out their closet of the clothes that are their eating disorder clothes. Like, yes, that's what we do when we're building that life worth living. We have to do community integration. We have to help them sometimes evaluate how they're living their life. Like I've had to help patients decide not to get a PhD or help an athlete maybe not return to their sport because it's really not working for them. Those are hard decisions. I never try to force those decisions, but sometimes it is talking to the families and saying, hey, this school that your loved one is going to it's not a good match. They're completely flooded. They need a school that has whatever, ADD attention or whatever, but just trying to push people along to just whatever, situation seems positive, is sometimes it's a miss. And providers have to be kind of opinionated about that too, and really make sure it's getting looked at.
Yeah.
Wendy, I love this conversation.
Oh my gosh, this could go on all day.
Yeah. I'm going to go a little off script and say, can we dig deeper into building a life worth living? Because more and more it is, when we're talking about that continuation of treatment, we've got to help them remember and build that life. Yes. So if you will share more of your thoughts on that and the community integration and how powerful
that's where things get locked in. Yeah.
Yeah. I mean, that's, the people that we deal with are the adults, over 18 and many that have gone through college and had jobs and lost all that, and have families and are dealing. And, the rest of their adult world that they know is moving on in that.
Or has moved on.
It has moved on, right? And so when they come out, hopefully into some recovery, whatever that is for them, those people are now gone, and have already moved on. And some of them, somebody I heard say, they expected them to still be there like they were,
their community
years ago when this person started this journey of the eating disorder.
Right.
And then and
then there's loss, right? Then
there's that feeling of loss and shame. And then the stigma of, oh my God, what have I done? It's terrible no matter when it is, but
it's that feeling of isolation,
that loss of those years of your life that you wanted those years.
About it so much, right? Even as we think about, as we're discussing it, it sort of like hits you even harder of like, wow, what a hard, overwhelming, horrible situation.
I mean, Emily was a doctor of pharmacy, and people said, my God, she's got it all going. She's got a house. She's a doctor of pharmacy. She's making this good money. How can this happen?
Yeah.
Why? You were great parents. You lived in the suburbs, and how did this happen? And people, and that just adds to that shame and stigma of the person that's going through it. Yeah.
It really does. Well, I mean, it's one of the problems that can be difficult in general with eating disorders, as opposed to other mental illnesses and substance use conditions. It's really, this is like really a nightmare, which is that the person with an eating disorder can actually, quote, look good on the outside, right? In fact, the person with the eating disorder oftentimes is getting socially reinforced for doing their eating disorder behavior, massively socially reinforced for doing their eating disorder behavior. So as opposed to substance abuse, like your doctor isn't going to be like, take another, snort of some cocaine, and why don't you drink a little more booze this week, Physicians are the number one or two, family members and physicians, depending on what you read, are the number 1 and 2 perpetrators of weight stigma. So I can't tell you how many times I've had to send a patient to a GI doctor, or they had to go to the neurologist, or they got admitted for appendicitis, or whatever was going on when they were under my care. And I almost feel like I have to run kind of defense before they interact with a doctor. I have to get a hold of them and be like, please don't comment on their weight. Please don't tell them that they look like a model. Please don't, reinforce their eating disorder. Please know what weight stigma is before you communicate with my patients. Please don't weigh my patients, et cetera. So it's like, I could go on and on, but I've had doctors' offices where I am friends with a doctor that runs the nurse. I know them. I'm like, don't weigh my patients. They don't need to be weighed. And it's like, they just are on this treadmill, and they just can't can't walk the patient in the door. That they're just it's like machinery or something. It's like,
it's the first check. It's the first checklist. It's the first checklist off the
first box. Yeah.
I'm put a big gigantic thing on the top of the chart in red that says, don't weigh Wendy's patients. But So getting back to your question, Ellen, it's hard to, it's, I always say this to my team and stuff, like, it's actually way easier to treat somebody when they're in residential level of care. Yeah, maybe they present, they're quote sicker at that time, right? But man, I got the whole team around them. If they're feeling unsafe, I can put them on a one-to-one observation. They're never alone. Every single meal and snack is supported. Like residential, that's like piece of cake. I love residential level of care. If I just only treat people residential and then I didn't have to worry what happened, that would just be a way easier job.
Yeah.
But unfortunately, that doesn't actually help the patient have their life after they leave your program. So then comes like, okay, now we actually have to like pull up our sleeves and like really get in there and figure out what's going on and help them build that life. And, I take issue even myself when I use the word with that term recovery, and I'm starting to get away from it. Just so you know, you'll start hearing me be more disciplined and moving away from that word, because so many of our patients, it's not about actually recovering something that they had before. A lot of times it's building something they've never had, which is peace within themselves about who they are as a human being, what their body is, what their relationship with food is, what is their authentic self, what do they really actually value in their life, what are their needs, what are their true actual needs. A lot of our patients are super bright, as you well know. Not all of them, but some of them are what I call almost like I call it like addicted to external hoop jumping. So it's like they've got positive reinforcement early in their life for being smart or being pretty or being something, above all else. And they're just so addicted to that external validation and positive reinforcement from external sources. And they have not oftentimes developed, I guess you would say, the muscle of their soul, I guess, their soul, like actually having a voice. Like they just don't know what's inside of them. They're sort of, in a sense, robotically getting through life. That's how come they can look so good on the outside. They can be, as your daughter was, a pharmacist or a physician or, the valedictorian at Princeton or whatever, and yet be so suffering so much. So the piece of why I was mentioning the high frequency of individual therapy is that you can't really get into that soul to soul connection by being haphazard about psychotherapy. And so building the life worth living, you have to know who that person is. They have to start to figure out who they are. And then once you've got that going, you got to stick with that. And then you got to battle all those social pressures that would maybe push them away from that. And then after you do that, or when you're doing that, you also have to like pull up your sleeves and help them actually do it. And that means that you have to, it goes back to reimbursement. It goes back to insurance, because you can't do this kind of work getting, rates that you can't support your team. You have to have a team. They have to be committed. They have to know what they're doing. You can't have like turnover and all of that. So building that life worth living takes a lot of time and energy. And I do believe in both Galen Hope and within, like going out into the community and being with patients and making sure you're actually getting it done.
Yeah, because there's pressures on the families too. It's not just social pressures; it's the family pressures to they've been dealing with this for so many years, and they're tired, and they had expectations, and some still want to hold those expectations for what their child can do, and it's hard for them to understand that, well, maybe they can't do that anymore. They've got to move on to something else.
That's right.
Yeah.
That's right. And that's sometimes, families obviously do get exhausted. And that's a really delicate conversation when you have to help a family members understand that whatever vision you had might not be the vision of how this is going to play out.
Yeah.
It all depends on the family.
Oh, absolutely. I'm not.
Sometimes it's more the patient, and sometimes it's more the family, and sometimes it's a mix of everything.
100%.
Yeah.
Yeah, absolutely. Absolutely. Yeah. We're not singling any particular person out. It can be the patient being, I absolutely refuse to not go back to Princeton,
Right. So, diet culture and body image profoundly influence all of our lives. We understand that social media doesn't just affect young people, it leaves its mark on everyone. Can you share your perspective on its overall impact on the patients you see dealing with all mental health illnesses, and also how they impact those with eating disorders?
Well, I think if I had to try to distill it down to something simple that like kind of is a part of everything, is just the concept of weight stigma, right? So weight stigma is a societal norm that is socially reinforced across many social institutions, medical, academic, media, just you name it, it's getting reinforced. And it really comes with, weight stigma is about judgment. It's about the negative judgments that we place on individuals based on their body size and shape, and the assumptions that go along with that about that person, and leading to the person having a devalued social experience where they're literally devalued as human beings within our society based on body size and shape, which is utterly atrocious and unacceptable and traumatic. And weight stigma is a poison. It's like a toxin that burrows into the person's soul. And when people are struggling to weight restore, or they're resistant to bumping the calories or gaining more weight or whatever, it's easy to just judge them and go, what is wrong with them? They have poor insight. They don't want to get better. They're not willing to do the work. I'm not going to work harder than they work. They haven't hit rock bottom. All this, may I say, bullshit, that really deflects responsibility off the clinician and blames the patient for their own suffering, while the patient may, yes, have to pull up their own bootstraps and do this work to actually get better. We also have to remember they're facing weight stigma, and they're trying to reduce the harm in their life. They're trying to make sure they have a place in the world where they're respected or loved or honored. And what I think is interesting, when you talk with a person in detail about why they are restrictive or why they're trying to lose weight, let's say, and you just keep going and going and going and going, and you just ask the next question, the next question, the next question, what they're trying to do, I'll just summarize it and generalize it, and I'm sure there's exceptions, but they're trying to do what we're all trying to do, which is every person I've ever known, we kind of want to be loved and accepted. We want to love, we want to give love, receive love, and we want to be accepted. We want to, I think, do something, manifest something from ourself of meaning in the world. Like you guys are doing this podcast. Like we have a yearning to create meaning in our life in some way, shape, or form, right? So if we overly simplify, the patient's struggle around doing this work of recovery, then we really miss an opportunity to find the common humanity among all of us. And we cannot overlook the impact of weight stigma. I mean, bring me a patient that's been bullied for their weight when they're in 4th grade, and that's going to be my anorexia nervosa patient that is flipping out when I'm trying to weight restore them, right?
Yeah. And interesting you say that, because we knew a young man who was on The Voice this season and ended up in the finals, right? He's from a local town right around here. And he was one of the 4 finalists. And one of the other finalists was a girl in a larger body. But when she told her story, she told about, and she had reiterated it about her being bullied, and because she said she had to learn to be herself and everything. So, she was going back in her life, and here she is as a finalist on The Voice now. But at the end, they showed pictures of her in the past, and she mentioned that she had anorexia nervosa at one point, because of, that bullying that she had. And she showed a picture of her, as a young girl. And so.
Well, and GLP-1s even make it worse now because they reinforce weight stigma because they reinforce this idea that, the body diversity isn't normal and that, that one ought to change their body. And while they try to say, oh, we don't blame the patient. And so they try to, the marketing tries to portray this like, okay, we're helping people by not blaming them. And we're just saying it's a medical ailment and here's the medication for it. But at the same time, it's also communicating that, if you're in a larger body, it is really not acceptable. And that's really been an alarming trend, obviously, that also, ties into this question of weight stigma and how we help people like build a life worth living, right? When they're bombarded with this stuff, it's literally a bombardment, right?
Oh, yeah.
It never actually stops.
Yeah. I mean, it comes out of Washington. When you heard, when it was, I don't know, months ago when they came out and they were guesstimating how much weight's going to be lost in the next 10 years by using these GLPs.
I heard about that.
Yeah.
Yeah, that was so sickening. Oh my gosh. And then there's certain cultures that are even more vulnerable to these kind of messages because of just the fixation on BMI, which is completely nonsense and non-scientific. And, certain populations are going to naturally have higher BMIs. BMI has to do with muscle density, bone mass, fluid, fat, all of the above. And so BMI is not a good determinant of health, but BMI is really still like, held on too tightly by the medical community as some harbinger of health and must not be above X, Y, or Z. And, very healthy bodies are above X, Y, and Z. I assure you of that.
Right. But doesn't that come from the insurance industry? Putting that. Well,
the BMI charts was the insurance industry like kind of was where that kind of derived from. But it's really the medical community that won't let it go,
Yeah.
Okay.
So
time is going by so fast. I think you're up next, Ellen.
Oh my goodness. I am going to thank you as a psychiatrist who is embracing the complexities of eating disorders and really looking at the whole person. How are we going to get psychiatry really embracing eating disorders and accepting?
Asking.
I have heard psychiatrists say they're not sick enough. Eating disorders.
Oh, yeah.
And so you are just so refreshing. So please, these eating disorders, the complexity, and you beautifully described it, is so intense. And the need for everybody being part of the team.
Well, I feel like I just need to take a breath before I answer because I have so many things in my brain, right? And I'm just like, where do I start? So it's funny that you should actually ask that right now because I did my residency at NYU a long time ago and there was no eating that when I said, oh, I want to do some kind of, I'd like to treat eating disorders. And they said, oh, well, we don't have any. I was like, do you have any supervisors? What can I do? And they're like, well, why don't you just start a group, Wendy? Because there was no like foundation. There was no education. There was no mandatory education for psychiatrists. So it's just funny that you should ask that because I just recently, not long ago, we started an organization called the Eating Disorder Education Institute, which the purpose of it is to broaden, like expand the field and to bring compassionate and contemporary eating disorder education to multiple disciplines, not just, preaching to the choir, but reaching out into the fields early on in people's training So that's going to be going live in June. But tied in with that is that I circled back to my roots at NYU recently, because in all these years since I've finished my residency, there still is no mandatory eating disorder education for psychiatrists. Like, somebody tell me how the hell this could have happened. I just don't get it. And all these years I've been doing this work, and I keep thinking somebody's going to make that happen. Somehow that's going to happen. And then if finally I started the Eating Disorder Education Institute, and it was just like, it never happened. Like, all this time has passed. It never happened. So I'm back. I'm circling back to my roots in psychiatry, and I'm working on that. I'm working on getting eating disorder education to become a part of psychiatry training, which means like psychiatrists will actually have to know what weight stigma is, for example. But what's really funny, my residency training director from NYU, her name is Dr. Carol Bernstein, and I love her. And she said, Wendy, it's going to be a project. And she said, it's going to be like a 2-year project for us to get like, for us to get like a sentence into the curriculum that says eating disorder training will be a part of psychiatry residency. Like, that sentence is going to take 2 years, but I'm on it.
Yes. Thank you. So critical.
Oh, yeah.
So critical.
Yeah, and you know what it is? It's good eating disorder education. It's not eating disorder education that's grounded in weight stigma, or that teaches food addiction and tells people to give GLP-1s to make people's hunger go away. Sorry, just being a little opinionated here, but
we love that.
Good. It's got to be good eating disorder training.
Yes.
Well, what we need going forward are wonderful role models for our young people. And you are a wonderful example of being a compassionate, kind, so intelligent person who is understanding of people with all these psychiatric illnesses, and especially eating disorders. So it is such a privilege to have this conversation with you. It just warms the cockles of my heart, whatever cockles of our heart are. But really, it does. And it's so hopeful for people going forward, for people impacted, for sure.
Oh, absolutely. Yeah, it's the frustrating part of what we do is we all want the changes yesterday, the changes that should have been there, a long time ago. Yes. And still seeing people suffering. We have all ages in our groups, and all, body sizes in our groups. And I truly, we dealt with anorexia. Ellen dealt with her daughter with anorexia nervosa. But, I do see the dismissiveness of people in larger bodies, and the people with binge eating disorders that, it's just stop. It was just, it's the anorexia, just eat. And then with them, it's just stop. Why can't you just stop? But
the thing that I love about our peer support groups for adults with eating disorders and for family members is the wonderful people that show up, and you can tell that they've had a lot of education and a lot of counseling, and the way they support each other just touches me so deeply. Yeah. And it's such a special part. It's such a special part of the healing picture for these people. Yeah. And for us too, because I know it's really hard to have the whole story out there, because you don't want people to judge your child. But it helped that Emily wanted her story told. But it also helps keep us going, because at least we can shed a little light in other people's lives, family members and adults with eating disorders, because adults so often are so much more complicated with adults. When it starts earlier, sometimes the behaviors aren't so ingrained, and it's not maybe quite as hard. All right, so my question is, I love how your treatment centers embrace co-occurring mental health conditions. We know that eating disorders never stand alone. Can you speak to this and tell us more about anything that we should have asked you and didn't?
Well, I just want to first circle back to what you said, Linda, about your experiences with the groups. And group experiences are so powerful. I mean, look at like the power of AA and how it's taken off. And like, so, finding others that have common themes, or just being, human among humans and vulnerable, or being able to like excavate the shame and discuss things more openly and not be isolated. The power of groups is like enormous. And I just love that you have that going on, and like special attention to the needs of adults also is really important. So I just wanted to say that and just honor your pain that you've been through, all of you. Easy for me to say, right? It just comes in passing, but you're taking that unthinkable loss that you've endured, that is every human being who's a parent, their worst nightmare. You've taken that pain and like turned it into something where you're actually healing people and creating those spaces in those groups, or even through this podcast. You're actually touching lives, and you never know whose life you're touching on any given day, right? That helps them make the next tough decision to do whatever they can do or need to do. And it's really through compassion and empathy that, that we are healers. And you are healers. You've transformed your pain into becoming healers. So I wanted to say that when you were talking about the group. As far as the psychiatry piece goes, like, I think that I was mentioning earlier that, I told you my story of why I decided to become a psychiatrist, and seeing somebody go from being psychotic to not psychotic. These eating disorders are, again, biopsychosocial conditions. There's genetically mediated personality traits and temperament. We know a lot more about temperament. That's also driving eating disorder: perfectionism, harm avoidance, etc. These are temperamental features that are, ingrained, and we're just born this way. I mean, I'm somebody that can multitask like crazy, and just whoosh. My daughter, if one of my daughters, she was texting me last night, when she has to multitask, her brain just kind of crumbles, and she gets really, really overwhelmed. But on the other hand, the one that can't multitask is like organized beyond belief, and has all of her pictures saved in her computer in the most perfect way imaginable. And I'm like, my pictures are just an absolute mess, so the psychiatric piece, yes, it's the primary psychiatric conditions that co-occur. A big one that's missed a lot is OCD occurs a lot. We all know trauma is like so important to address. And it's not just the traditional trauma of the overt, very obvious forms of trauma, but there's something called CPTSD, which is a type of trauma that doesn't necessarily meet the eye when you get the history. So addressing the trauma, the OCD, the major depression, the bipolar disorder, whatever the case may be, the social anxiety disorder that's reinforcing, substance use that co-occurs with the eating disorder. We can go on and on and on. But if we leave that unaddressed, then the eating disorder has more reason to be there. So we kind of have to take all of that into consideration. So when you mention psychiatry, I want to mention, yes, the co-occurring psychiatric conditions, and then the temperamental features. Very frequently, when patients come into higher levels of care, they've had inadequate workup for co-occurring psychiatric conditions, and they don't get assertive psychiatric management. So they have OCD, but they've been on like 20 milligrams of Prozac for 2 years. And it's like, well, actually the treatment for OCD requires high doses of SSRIs. So the person's being inadequately treated. So as we wrap up, I'll just say, so often when the person's not getting well, it's not that they failed treatment, it's that treatment failed them.
Mm-hmm. Yeah. Mm-hmm. Yeah. We're hearing that more and more. Yeah. More and more.
Yeah. I've been saying that for a while.
Yeah. Thank you so, so much. We extend our sincere gratitude to you and to our listeners and to our special guest, Wendy. Again, one more time, I just can't thank you enough. We would also like to thank RockVox Recording and Production and Scott Fitzgerald, our remarkable sound engineer, for his exceptional production of our podcast and so much more.
Tell everyone about Once Shattered, Picking Up the Pieces. Please rate, review, share, and subscribe on the podcast platform you're listening to us on. And check out our YouTube channel. Learn more about Linda and Jack Mazur, founders of the Emily Connection, the nonprofit formed in their daughter's memory, and the important award-winning heartfelt book they wrote, Emily, the story of a girl and her family hijacked by anorexia, available on Amazon.
And as always, thank you to our co-host, Ellen Bennett, the color person on the panel here, who brings over 25 years of lived experience, community engagement, and advocacy. Oh my God, so much advocacy she's done, and raising awareness and challenging the stigma associated with eating disorders and all mental health. The discussions here we have with our guests are incredibly important. Thank you, listeners. And again, thank you, Dr. Wendy Oliver-Pyatt, for taking this time. And you are truly a gift.